So recording has now started. Okay. Okay, so let's get started. So our topic today is teledentistry for people with disabilities, and the reason why we're doing this is because COVID-19 has really taken over the world. It's very transmissible and has high mortality rates. And this virus, it's disproportionately affecting vulnerable groups who we care for, such as people in older age and people with underlying diseases. And it's affecting them in severity and reach. So the average age in Ireland for people dying of this, the median is about 82 years of age, and many of whom have multimorbidity, and many of the people who are dying also have underlying medical conditions. So the challenges of COVID-19 that most of the world are facing are exacerbated for our vulnerable groups who we see in special care dentistry. If we look at long-term care facilities, for example, there's been 32% of all clusters in Ireland have revolved around long-term care facilities. So that's 86 clusters. So 32%, which is phenomenal when you think that this is such a small proportion of the population. And when we think about where the other clusters are happening, in total, 2/3 are affecting vulnerable people. So we've got 46 clusters in hospitals, 33 in residential institutions, and 16 in long stay units. So it's our population, this vulnerable group, who are disproportionately suffering this. And so without any vaccination or treatment that's been effective, the mainstay of treatment of this virus has been social distancing, diagnosis and contact tracing, restricting movements, respiratory etiquette, hand hygiene, and socialization of vulnerable groups in most parts of the world. Now, many of these measures are incompatible with traditional healthcare models, particularly dentistry. So when we look at dentistry in relation to the mainstay of treating the disease, what we find is we see real extreme proximity, mucosal contact, splashing of bodily fluids, generation of aerosols, social congregations, all of which go against how we need to manage this. So this is made worse by the potential of asymptomatic transmission of the disease as well. So times have really changed, and the above must be considered when we weigh the benefits of dental treatments and traditional dental treatments, particularly for vulnerable groups. So whereas attending the dental clinics once seemed really reasonable, now the balance of risk for such encounters just aren't that clear for the dental team, for the public, and for our patients who are vulnerable. So what is clear is that all steps to reduce the risk of dental visits will be taken in the context of COVID-19. So there's been some guidance from around these countries about how dentistry should react to this. And in Northern Ireland, in Scotland, in Wales, and in England, the advice has been to switch towards telephone-based services to triage people to avoid the use of dental care. And just been more broader steps taken, but all of them agree that we need to mitigate this by using remote consultations, and if and where possible, remote treatments with things like advice, analgesia, and antimicrobials. And there's been some fantastic work from the Scottish Clinical Dental Effectiveness Programme on both of those aspects. So we're in a new age where not going to the dentist is a new going to the dentist. And we dental professionals, we're not used to novelty. We don't like risk. We don't like disruption. We work on the same procedures again and again to perfect them. So we're in a stage now of disruption where the fundamental basis of our concepts of care is changing. And the process in which we provide care and the way in which we manage risk is changing. So teledentistry sits comfortably within our need. It seems to be the answer to many of the new problems that dentistry is facing. So for that reason, we are having this conversation today to explore from a number of different angles what teledentistry is adding. So we're going to talk to some people from Ireland and other near countries about what their response to the use of teledentistry has been to address these issues. We'll then talk to Joe Werton from the team in Oxford about how medical practitioners have been dealing with this and his experience in doing his research in that. We'll talk to Nicholas Martin from Sheffield as well, who has recently published in the BDJ on the comparison of teleconsults and face-to-face interactions, and we're going to learn from him. I'm going to talk to Mark Ackerman from the Tele-Dentistry Association about how what we can learn from people who have been using this technology for quite a while, and then we'll finish up then. So that's probably enough from me at the moment. What I'm going to do is I am going to bring in the first of our large panel. I'm going to ask Ahmed to come online, change all to, I'm going to start video. And Ahmed, how are you?
Hi Kev, how are you? Very well, thank you.
Good, good, good. Well? Yeah, I'm good, thanks for coming on. I am going to try and get your video up here. Sorry, stop video. This might help. No, Ahmed, I can't seem to, oh, okay, here we go. Ahmed, there you are there. Ahmed, can you see if you can get your video up and running for us, please, as well?
Yeah.
Great stuff. Okay, thanks, Ahmed. Ahmed, so you are working in private practice that treats people with disabilities in the Greater Dublin area.
Yes, yeah. So our practice, well, thank you very much, Kev, for that great introduction, and especially in the context of the patients of our interest, which are, you know, patients with special healthcare needs, and that's exactly what that's exactly who we treat in our practice. Primarily, it is a general practice, but I'd say about a quarter to a third of our patients are people with special healthcare needs. And yes, we've switched to a almost complete teledentistry practice now, considering the guidance in Ireland. You know, way back in the 27th of March, which seems like ages now. In the context of this, there's been restrictions to restrict all services to emergency only, and the Health Protection Surveillance Centre and the Irish Dental Association have subsequently encouraged teledentistry wherever possible. So a lot of what I'll be talking about in terms of how we've implemented it is quite translatable and quite inclusive of everyone in the population, obviously especially the people with special healthcare needs. So in the last 2 weeks, we have been working exclusively with teledentistry as a form of caring for patients. And people, in terms of the response we've received, they've been quite obliging. Many of the patients, I'd say over 95% of the patients have been very understanding, and they, you know, with the media and the positive spread of reliable information, they also see the importance of the steps that we're taking in the greater context of society ultimately. So we inform our patients through message, through emails, through social media of our switch to teledentistry, and we've also given them an emergency contact number, and that's in keeping with our dental council policy that all, you know, dentists should provide reasonable out-of-hours service as well. It's important, even in the middle of this pandemic, that we try and stick to policy and guidance as much as possible as well. So in terms of teledentistry then, and how we've implemented, we have a team of 3, 2 dentists and 1 receptionist, and the receptionist manages the administration side of things, and she filters the phone calls, and she's very, very good at it. She works from 10 to 1, Monday to Friday. So the receptionist, she's very good, and she's trained to provide advice for low-level discomfort, and recognize a dental emergency, and then refer on to either dentist, me, or the practice owner. She also checks the medical history, and that the medical history and GDPR forms are completed and up to date. And if not, if they're not completed with our regular patients, then we send a copy to them for them to fill in and then scan back to us later on in the day or the following day. This is also useful as well as record keeping, which is important to bear in mind throughout all of this. It's also useful to identify COVID vulnerable patients, and also useful for prescribing ultimately. So the dental emergency, if it still persists and they would still like to speak to the dentist, then receptionists pass them on to us. And she encourages them before our little chat that, if they can provide video or photo kind of evidence to kind of help with our diagnosis, that'll be even more useful. I think this is
how are you getting those pictures in, Ahmed? What software are you using?
Absolutely. So at the moment, it's no real special software, simply because most patients don't have it. It's through WhatsApp. What's important to bear in mind is obviously, the whole idea of data protection. Interestingly enough, the Data Protection Commission has published a nice information leaflet in kind of securing your data in the context of COVID, and it's well worth a read, actually. Important things to bear in mind would be, as soon as you've completed your use with the photos or videos or the information, you delete them from your phone. And the Data Protection Commission are quite have recognized the kind of efforts we're trying to make here, and how a lot of personal data has had to move from the professional setting into the personal setting, and they're aware of it and they're understanding. That's a very useful document to read. Yeah, so aside from that, then this is a service then that I think ultimately does kind of necessitate a fee for, and simply because it's providing a professional advice, and it gives peace of mind to the patients, as well as our prescriptions and admin and all of that. So once they then come in contact with us, we review their charts. We have the way we do that remotely is through TeamViewer, which is quite a secure form of viewing the information on our computer in work remotely. And then we set up a file up for them. We add notes onto them. Again, once we've talked to them, it's important to continue writing your contemporaneous day notes as you would usually. And again, that's in keeping with dental council policy. And then we give them the option of either audio or visual communication as a form of communication that they would prefer. Usually it's audio, interestingly enough. We found most patients prefer just audio. And then we proceed to kind of manage their dental healthcare need using some of the guidance which is out there. Quite a lot of useful, very, very useful guidance. SDCEP, for example, the British Endodontic Society, and the IDA, the Irish Dental Association, all have steps in managing dental emergencies that are very useful. A nice point is that, a very useful point is that we get the pharmacy's details quite early on in our conversation, so that we get the list of their medications, and it also allows us to establish a prescription pathway in these instances. And as I'd say, a lot of you have found, most pharmacies have been very, very accommodating in the special circumstances. There is some software to allow electronic prescriptions. We've managed so far by scanning prescriptions with encrypted PDF files through to the pharmacies, and they've responded quite well to that. Most pharmacies require to... Sorry?
Are you following up then with a paper-based one as well, or are you just leaving it with the scans version?
Absolutely. Most pharmacies again, do require a paper trail after that if it's not an official electronic prescription. And they usually recommend doing it within 3 days after the prescription has been made, which is, it's plenty of time.
And thanks very much. I think that gives us a nice idea about where you're coming at this from a private practice perspective. And so you still find your feet. Have you found this? How comfortable have you been with this transition? Has it been something that's been more difficult than you anticipated, or is it working okay?
Yeah. So honestly, it's been quite a good transition, to be honest. It hasn't been too far of a stretch from what we're used to generally, in terms of history taking, in terms of our, much of our diagnosis comes with the first, 10 minutes of conversation with the patient every day. And that's something we can do remotely. So it hasn't been as much of a shock as I first thought, and patients are quite accepting.
Anna, thank you very much. I'm going to bring in Jennifer now. Jennifer, how are you? Jenny?
Sorry, I think my internet connection's quite poor. Can you hear me okay?
Yeah, I can hear you fine, Jenny. Thank you very much for joining us.
No problem.
Just give people a bit of background. Who are you and where are you working?
Yes, so I'm working in the dental hospital in Dublin. And normally I'd work across a variety of departments. Currently, we're all working in the A&E department, only providing emergency care. And kind of similar to what Ahmed was saying, we're triaging all phone calls over the telephone. And then depending on our criteria, then if we accept the patients, we're giving the names to the porters, and then the patients are coming to us. However, obviously we've had calls from all over Ireland because a lot of dental practices have obviously closed. So we're experiencing a huge volume of calls. So it's important for us to have like a kind of strict criteria of what we're accepting at the minute.
Okay, and can I ask then, with the number of calls that are coming through, is that greater than maybe the number of footfall patients that would have been in the past?
Oh yeah, it's hard to tell because it's different when people are just kind of showing up as such. But we had 196 calls last week, and that was between a 6-hour period from Monday to Friday. And some of those calls can last, 15 minutes or 20 minutes. So basically we've had to change. Even this week, we only had one person on the phones initially triaging. We've had to up that to 3 people on the phones because there's been complaints about the waiting time to actually speak to someone.
Wow. And they're all clinical. They're all dentists.
They're generally patients. I've only had a couple of calls from actual dentists. Generally,
the people who are manning the phones from your side are dentists. They're not admin.
All dentists. So either JHOs or SHOs. And
you guys, what software are you guys using for this? Are you using?
So we just have a telephone set up, and then we've got like an Outlook kind of set up so we can record the data of the name of the patient, the date of birth, where they're calling from, and then their complaint and what our advice is. And we're seeing, we are, like a lot of people I know are saying that pain isn't really an emergency. However, we are taking into consideration severe pain, where if like analgesia advice hasn't helped, then they can call back, and then we are arranging to see those patients.
Yeah. It's quite a different way of administering that, isn't it?
Yes, it is. The other thing is we don't have a video consult set up yet. So we are asking if it is the case, if it's a suspicious lesion or if it's a swelling or trauma, we're asking for photographs to be emailed to ourselves. They're still working on getting a video consult set up, but we don't really have any further word on that at the minute. So we're really using our emails to receive photographs, which then we can delete.
Yeah. That seems to be the way a lot of people are working this, is trying to figure out the most appropriate in the context of the now, I suppose. Can I ask Jen, what about proportions of people with disabilities and vulnerable groups? Are you seeing many of these people coming through?
Not particularly. Now, we've had some phone calls about certain elderly parents, but not within care homes as such, more within more within a family kind of setting, like a mother calling or a woman calling on behalf of her mother who's elderly, and there's been maybe concerns about bringing them in. But no, not really, not a huge proportion of patients with special healthcare needs.
I'll be very interested to hear what our other panelists are saying about the proportion of people coming in with special healthcare needs. Jennifer, I really, really appreciate you taking time out from your busy schedule to talk to the group.
No problem at all.
Okay, thank you very much, Jen. I'm going to come on
Not at all.
I'm going to go on to Helen. Helen, you're over in Scotland. How are you?
We're trucking along. Just you asked about people with additional needs there, and as we've got the learning disability group, and it's been quite quiet, and I'm just a wee bit worried about when that's going to blow up, because we've got a massive waiting list for treatment under GA, and oftentimes we've listed them because they're in pain, and I'm surprised by how quiet that's been. And I'm just kind of waiting for that the tsunami to come, and hopefully at the moment they're okay. In terms of teledentistry, which is what you really wanted to talk about, I think today, Kev. As you know, our system is that we've got the GDPs are all staffing their own practices, whether bodily or remotely, and they're managing triage in the first place and going down the AAA protocol. And then if they feel somebody needs treatment, they come to us, and then we then phone the patient. We've got the patients to send photos in for us. Intraoral's not terribly successful, but extraoral, we found that quite useful for swellings. And we haven't used it for trauma, but I think that's another area that it would be really, really useful for. Just as a clinical aside, we've had 2 cases of mumps. So that, of interest. But I've been trialing a video consultation software package called Attend Anywhere. But it's great. It looks really good. Sitting at my desk and the other person sitting at their desk because they're another staff member, and they're clearly computer literate. More difficult if you don't have good reception. And I've also just discovered today, we're very lucky. I think people are talking about using WhatsApp, and it makes sense, but we know there's issues with confidentiality and the governance around that. If you've got a practice number that you can then use for the WhatsApp, fine, fair enough. I'm quite concerned about people's personal mobile numbers going out. I think you can. I'm not quite sure if you can block it on WhatsApp. I'm not that IT savvy. But we have because we're set up here in the Public Dental Service, we have a generic email address. The problem is, one, patients struggle to send emails to us because the generic email address is, one of these horrible, complex, long things. So we thought, right, we'll email them and then get them to reply. But we've struggled because it turns out our generic email address can't email certain people or certain email addresses, and I'm not quite sure what's going on there. And so the Attend Anywhere depends on you emailing a link to patients, and it's fine to an NHS address or a local NHS mail address, but I tried to send it to a Hotmail account this morning and it didn't work. So so do I then need to email everybody? And then most of the west of Scotland has my email address, which is not ideal. So I think there are issues. The Attend Anywhere setup is really nice. It's very clear. I need to investigate it. We haven't used it with a patient yet, but we are using photos where we can, and they can be quite helpful.
Okay. So it seems to be that, and from lots of conversation I've been having with other people as well as the conversation here, there's lots of people recommending different solutions, technological solutions, and it can be quite hard to figure out what the way forward is with it. It can be quite tricky to know which way to go. And as we can see there's issues that only come up once you've invested the time into learning them and getting them going. It can be quite challenging. Do you think that one's going to take off?
The Attend Anywhere?
Yeah.
I sincerely hope so. In fact, I think what we need to do is get advice from medical colleagues, because I know they use it quite widely. And like in the islands, I think they've used it for some time, where there are accessibility problems for anyone. But I know it's being used more widely now. So I think we probably need to converse with our medical colleagues and find out. I think we've probably mentioned this before, this crisis is fairly horrendous and challenging. It's showing us new ways of working, which in the future we might find useful, in terms of reducing the need for domiciliary visits, or cutting one stage out of the process. Again, there needs to be a certain level of IT savviness, but that people are more and more IT savvy, aren't they? And particularly people with physical disabilities who can't get out the house or whatever, they are forced to be more IT savvy in many cases because they use new technologies.
Helen, thank you very much for giving us an update about where you are. I think it seems to be we're still at this. I'm sure there's organizational science phase names for these phases, but we're near enough to start.
Yes.
Thank you very much. I'm going to bring in one of our medical colleagues, or definitely someone who has a lot of experience with our medical colleagues on this. It was Joe. I'm going to ask you to pop on and start your video there if you can. And Helen, thank you very much. If you can stay with us, great. I know you're busy. If you need to run, that's okay. Thank you so much for coming on. Joe, good afternoon. How are you?
Hi, Kev. Can you hear me?
Yeah, I can. You're welcome. Joe, do you want to just tell us who you are, why you're here?
Absolutely. Thanks for having me on. This is really fascinating, actually, hearing about people's work. So just to give you a little bit of background, I'm not a medical person at all, but I'm actually a psychologist with a research background in human-computer interaction, so how people use technology, but specifically in healthcare. And so I do, as you say, work with many medical colleagues, some of them using video consultations. But I'm based in a research group in Oxford. And we've been doing work on video consultations for, I'd say, for about 10 years now. And during that time, the uptake of remote video consultations has been incredibly slow. You might get these kind of small scale pilot studies, and you get these sort of little pockets of success in these kind of clinics, but it's never been mainstreamed, it's never been rolled out. It's kind of business as usual in clinical practice. And I think one of the reasons for that is really related to what a lot of people have already talked about, which are the kind of logistical challenges of embedding this within routine practice. It's not just about installing a technology, it's about how you align that with all sorts of other work processes and administrative processes as well. But the other challenge as well is the kind of clinical aspect. And in particular, a challenge for clinicians is how you decide when it is appropriate and safe to do a video consultation. And what we found in the past, pre the kind of COVID crisis, is that generally clinicians consider it appropriate and safe for appointments where, the patient's condition is stable. It's a fairly straightforward, kind of predictable condition. And also if the patient has kind of good knowledge of their illness as well, then it seems to work well. And also, obviously you can't do a physical examination, but it is possible to do limited, assessment. But again, that involves some skill on the part of the consultant and, kind of collaboration with the patient. So really what we found is it's actually been used in a minority of situations and tends to be used in secondary care for things like routine follow-ups with diabetes patients and things like that. But obviously with the new situation with COVID, what we've seen is a complete change. And what it's done essentially is it's shifted what you might call the relative advantage. So the risks of doing something over video are highly kind of outweighed by the risks of doing the appointment face to face. So what's happened is the kind of questions changed from you know, it's not so much about, well, is video better or as good as face-to-face? The question now is, how can we do video as best as possible and make it as good a quality consultation as we can? And so what we've been doing in Oxford is drawing on the lessons that we've developed over the past sort of 10 years and adapting that for this situation to support the rollout of video consultations. I can send some links to some of that guidance, and it's also in ongoing development. So the Health Foundation are going to be putting some guidance on their website that we've developed that people can access. And we've not actually done any work in dentistry and oral health, but a lot of the lessons and the resources we've developed will be transferable to all sorts of clinical settings.
Do you know what I think, Joe? I think what's going to be interesting for, I'm going to ask you for, when you talk about guidance that you guys are developing, I'm going to ask you what type of guidance you might give a group like us in a second. So if you want to think about that, but there's two things that jump out to me when we talk about special care dentistry and video consultations. The first one is that dentistry, we're cutters, we're operators.
Yeah.
We are, whereas a GP, and we're all very comfortable going into a GP for 20 minutes, talking to him, getting the script and leaving and paying the money and thinking, okay, that was a medical consultation. Dentistry is very different. You know, you wouldn't, dentists aren't used to operating on a like this, like face to like, or on a non-operative scale. So that's one thing. And another, maybe if you have perspective on that, another thing then is, our patients are patients who are vulnerable, maybe with disabilities, hearing impairments, visual impairments. Has any of your research looked into how people with disabilities or communication issues are interacting with this type of tele consultations?
Yeah, I mean, I don't think, obviously there are situations where it just wouldn't work. So if you're working with a person with, say, mild to moderate dementia, then it's there's going to be a lot of difficulty at doing a video consultation with completely unfamiliar technology, let alone getting them to know how to access that technology. But generally speaking, those types of arrangements tend to have someone else on hand who can support them. And I'd be fascinated to hear, what sort of appointments you would do in your particular clinical setting through video. As I said, obviously, you can't do anything physical to the patient, but there are some quite surprising ways in which people have managed to do visual, assessments. So I had a colleague who's a GP practitioner with a special interest in cardiology, sent me an email the other day, and actually she was able to do a fairly good assessment of a patient who was showing quite severe COVID symptoms by listening to the breathing. Even getting, because it was a mobile phone that they had on the other end, and actually looking at the patient's tongue over video. Now, obviously, there's issues around lighting and the quality of that image, but given the current circumstances, it's sort of the best guess you can get, really, for this sort of situation. But there is the clinical consultation bit. But then one thing that's come out a lot in the discussions so far is the logistical kind of administrative bit as well. The kind of practical aspects, which we also cover in this guidance. I suppose one thing to draw your attention to, and it's something you've mentioned already, is what platform to use, type of setting. And obviously there are all sorts of different video platforms you could use, such as the one we're using now, Zoom, you've got Skype, FaceTime, and so on. And people do manage to use those, but these technologies weren't really designed for this kind of complex clinical workflow. They're designed for meetings. Yeah. What we found is they often, while you can use them on a small scale, they don't really interface that well with kind of routine clinical practice. But where we have seen successes is where they have moved towards the more bespoke technologies. And Helen mentioned Attend Anywhere as something that's being used in Scotland, which I think, looking at those types of technologies is well worth doing, because what they've done is actually design the technology in a way that tries to mirror the standard outpatient workflow. So for example, it has a virtual waiting room. So the patients go into the waiting room, and then the admin staff or the clinical staff can see the patient virtually come into that waiting room and then call them in. So what that creates is a kind of mutual awareness between the patient and the other staff members, which, you know, you'd get in a physical appointment. You know, if the patient goes to the waiting room and the clinic is running late, you know, people are okay because they kind of know what's going on. But if you did it via Zoom and no one was connecting because the clinic was running late, it could cause some confusion. So those types of bespoke technologies that kind of understand those slight issues around the flow of an outpatient workflow are quite important to look at. And Attend Anywhere is one of those.
Joseph, Joe, you're a Trinity College alumnus, I believe.
Sorry, say that again.
You're a Trinity College alumnus, I believe, are you?
I am. I used to be at Trinity. Yes, yeah.
Trinity guys, okay. Joe, thank you so much. Thank you so much for your advice here. If you can hold on for the discussion at the end, there might be some questions.
Yeah, I'd love to. Yeah.
You have to go. Thank you so much. I really appreciate that. Now, we're going to take what you've been talking there and look at it through a specific dental lens. So I'm going to introduce Nicholas Martin, Professor Martin, who's coming in from Sheffield, who has just done published some fascinating and, dare I say, the most timely research ever published. Nicholas, thank you very much for coming on board.
Hello, good afternoon, Kev, and thank you very much for this invitation. It's tremendous to be joining you. Yes, it's fortuitous, isn't it? Our work, so I'm an academic clinical consultant in restorative dentistry, based here at the University of Sheffield, and I work in the Charles Clifford Dental Hospital. I'm not from your background or special care dentistry, although I did spend quite a couple of years in that area in my formative years, so I know where you're coming from, and I am quite comfortable with the challenges you face. So much of the work we've been doing has been not really considering COVID, obviously. We never envisaged that we'd found ourselves in this environment. And equally, for many of the reasons that Joseph has just been explaining, much of our work has been focusing in a dental care practice, in a dental practice environment. So Joseph and Helen and Jennifer have highlighted the challenges of going, especially dentist to patient, and the connectivity problems there, data security problems, and obtaining the right sort of data and information that needs to be transmitted so that you can, as a dentist, establish the right, make a reasonable assessment and establish the right diagnosis and treatment strategy. So for accepting that those challenges were there and they were never going to go away, and primarily because of the need to be able to undertake a clinical assessment, a very thorough one, we went for the route of doing these things in practice. So the concept being that that I would be, as a secondary care provider, I would be in my office in the dental hospital, for example, or wherever, or at home, where it doesn't matter, and the primary care provider would have some kit. And this could be effectively in their own surgery, if it's a multi-surgery center, and it could be a kit that could be moved around in a suitcase, or it could be in a healthcare setting. So effectively, dentists could book themselves in maybe for a session, say on a Monday morning or Thursday afternoon or whatever, and have a list of patients booked in for that session. A list of patients for which they would wish to have a second opinion. And this is very much to replace our current very cumbersome and somewhat primitive system that we use at the moment, where a dentist writes that letter, very often handwritten letter, can you please see and treat this patient for X, Y, and Z? And then the patient, an appointment is made, and then 8 weeks later or 10 weeks later, the patient trundles along, grumbling and moaning that they've taken them all day to get there and couldn't park. And then we see them, and they walk into the dental hospital, a really bizarre, weird environment with hundreds of dental chairs everywhere. And if that doesn't put them off, nothing much else will. And then they go into pokey into a little surgery. You ask them to sit in a chair, ask them to put themselves at ease, and then you undertake the assessment. And that's how we do it. Then we report to the patient what we can do, and then we tell them, and then we write a report back to the dentist. and then the dentist has to discuss that with the patient. So no point do you ever get the 3 people together. At no point, it's not really patient-centered. The patient is very much like a ping pong game between you and the dentist. So the idea behind this, the main drive was to make it more patient-centered, so that any decisions that are made as a threesome. So and the decisions that the patient is comfortable with, but just as importantly, decisions that the dentist can actually implement. There's no point me saying, oh, you need X, Y, Z, and the dentist say, you know what, that consultant in Sheffield, he's off his head. There's no way we can do this, or it's going to cost a fortune, or whatever. Yeah, so it has to be, and there's where the drivers. Anyway, to cut a long story short, that's the route we took, and we set up as you explained, Kev, there's a paper that just got published last week at the BDJ, and it's explained pretty much what we've done, so I'm not going to get in detail with it, but it worked well. The idea was
very impressive aspect to it, Nicola.
Follow me.
For me, it was a very lovely design. What you guys did is you set up the remote consult.
Yes.
And it was like one of those game shows where the person's just behind the door.
Indeed.
You come in after the teleconsult and then do an actual consult.
Well, the whole point was what we really concerned about, because ultimately we want to be able to sell inverted commas, the concept to the providers. And the really important thing is that it must be as safe as an in-person consultation, because that's the first thing to be throwing at us. Is it as safe as? It doesn't matter if you like it, or the patient likes it, or if it's cheaper, or if it's better for the environment. All those things are really secondary, because nobody wants a lawsuit. So it has to be, from the care providers, for the primary and secondary care provider, it has to be safe, or at least not inferior to an in-person one. So that is why we did it. Sorry?
Was it safe?
Yes, it was basically, the whole point was that we did the remote clinical consultation. And as you said, then immediately after, we walked into the surgery and did the in-person one to make sure that we hadn't missed anything. We wanted to say, okay, everything I saw remotely, is that what I can see for real now? And would I have reached the same diagnosis and treatment strategy based on what I did before? And it was every time. There were a couple of instances where there's some things that became more evident. So, for example, we had quite a unique patient that had quite a severe scleroderma, and that is where the whole system. We didn't have the tactile feedback. So the dentist was explaining to me, that I can't get into the patient's mouth very easily because limited opening, etc. So we had that information, but we couldn't. But it's not until I went and did the clinical consultation in real that I actually felt the lips and the cheeks and felt like cardboard. I thought, wow, this is actually going to be a real challenge now. So the subtleties, very specific subtleties that clearly are not transmittable yet through remote, because you haven't got the tactile feedback. The thing that we did feel that was important, the way we set up the surgery, was to have all the same information as you would have in an in-person one. So those subtle indicators, when a patient walks into the surgery and you see they're happy, grumpy, or they can't walk well, or they come with a huff, or you see they're out of breath, those little subtle things, you want to pick those up. So we had cameras in the corners of the room, so we could see that. So I could see exactly as the patient walked in, the same as I would in person. And then we had a camera over the chair, and then the really important aspect was the intraoral camera. So we had a live feed from all these things. We had a very Heath Robinson setup for this particular pilot. But now we're actually moving on to the next stage where we can do it in a true primary care setting. And that bizarrely was going to happen in 3 weeks' time. Yeah. So we got the ethics and everything else. We got the funding, and we were going to do it in a true hospital and primary care setting, and with bespoke software that we've had designed.
What were the things that caught you out when doing this? What were the issues that arose when trying to do the equivalent teleconsults? Okay,
the main issues were, well, one of them was as a slightly Heath Robinson technology affair we had. We just had literally some webcams glued onto the corners of the room and the intraoral camera and so on, and that all worked well. But what we've learned from it is the importance of a protocol. So the dentist that's going to be using has to follow the same clinical assessment protocol. So effectively, I'm driving the dentist remotely. I'm saying, okay, can you now show me the lips? Now can you take the intraoral camera and show me, go from the lower left buccal mucosa, now show me all the teeth buccally, now show me all the lingually, now show me the tongue, now show me the palate. So you have to have because otherwise you go all over the place and it gets very confusing. So you have to find effectively a roadmap as to what you want to see and how to see it. And you want to make sure that the dentist understands your instructions. So when you say, can you pan out so I can see this better? Or can you show me that in more detail? But it's just literally how to formalize the communication. And that is what we were going to do in this next study. We've actually designed the protocols and a very small element of training so that the dentist knows how to use intraoral camera, etc. But other than that, no real issues. We found that the acceptability by patients, they absolutely loved it. Huge levels of acceptability, fundamentally, because one of the things we've realized, and that maybe Joseph will be able to, as a clinical psychologist, confirm, is that we find that using internet communication like this, it lowers the hierarchical imposition. So if a patient walks into a surgery and there's a consultant, immediately become quite intimidated. And if you had the patient and the dentist and the consultant, the dentist, okay, well, I'm not going to say anything because I don't want to put my foot in, he'll be embarrassed. But with this type of environment, everybody sort of drops down to the same level. And it becomes the discussions are much more fluid and much more honest as well, which we found to be very effective.
And I think that's for special care dentists here. I think we're probably all nodding our head at that reduction of the hierarchy, because we understand how important that is to get through.
Yeah, absolutely.
Or translating this into disability in the COVID era now.
Yes, yes.
Do you think that this is that remote consultations is viable for the people who are trying to set up now? Do you think that it's safe and effective?
Yeah. The problem is clearly in the COVID environment, you wouldn't. I mean, if there are two scenarios. If you do it with the dentist and the dentist in a surgery with all the PPP, then that would work well. I'm sure that would work very effectively. I think the great bonus is that your patient with that disability will be comfortable with that dentist. Presumably there's already a rapport. Sometimes there's a rapport because they know each other. Even if there's a rapport isn't there, being in a smaller surgery rather than coming to a big hospital clearly is better for the individual. And be able to transmit that information, I think, as the dentist transmitting that information to a specialist consultant or whoever, I think that would work well. In a patient to dentist environment, I think that's probably more challenging for all the reasons that have been said before, where the quality of the data that's been transmitted and the worry of whether you're making the right diagnosis or not, because you don't know if you have missed something or misinterpreted something or jump into conclusions based on the information that you've been given. So I think there are risks involved associated with that, but some cases are quite clear cut.
Yeah, I think this reminds me of what Joe just said earlier on, that we are no longer looking at an efficacy comparison of effects, rather it's within the context of the risk dynamic now. Is it reasonable? And it seems to be coming up trumps. Look, Nicholas, I really appreciate you coming on and talking to the
pleasure. It's a lovely meeting anyway.
It's a really inspirational article. And actually, I went to my own boss's Witcher article and I said, look, can we start looking at this type of model within COVID for disability in Ireland now? Seeing that, coming back to Helen's point earlier on and to Jennifer's, and something that we're seeing as well, people with developmental disabilities don't seem to be accessing emergency care as proportionately as people without. So it might be that these type of different models might be a solution. So Nicholas, I really thank you.
But that's interesting, because what I'll do, I'll speak to, I never thought of disability groups. So I'll speak to, when we get back to normality, chat to our oral special care needs group, and maybe there's something that can be done there.
That sounds very interesting. Keep me in mind, Nicholas. Sorry.
Absolutely.
Nicholas, thank you very much. I'm going to bring on Mark.
A real pleasure.
Real pleasure, man. Thank you so much. I'm going to bring on Mark. Mark, you're calling us from the other side of the world, and I've worn my Boston top especially for you. I think it's Boston. I'm not sure. I'm going to see if Mark, you're there. Mark, how are you?
Good, good. I think they call Boston Dublin West, right?
That's not a compliment. That's not a compliment.
Yeah, we like our Irish. But I come to this discussion with several different hats. I was editor of Special Care and Dentistry Journal for 5 years. That's how I met Kev, through his submitting really good articles. I'm a clinical orthodontist, but I treat quite a bit of patients with intellectual disability, from autism to Down syndrome to orphan syndromes, as well as physical disability, and a lot of kids who've had significant medical issues that have compromised either their growth and development or other issues. I also founded the American Teledentistry Association 2 years ago because I thought this was going to be a very important adjunct to what we were doing in our hospitals and dental clinics. I practice at a hospital full time, but outside of it, the year I started this, I was also in a private practice. I practiced for a decade in private practice before going into hospital setting for the last decade. And what I found is that, particularly in the special healthcare needs community, having something is better than having nothing. And that's been all of our mantras for getting access to care. So what I found is that some of these parents who were told, you know what, we could never consider orthodontics. We were told that he's just not a candidate, she's just not a candidate. What I've done over the years is a number of desensitization visits, just getting to know the child, or even young adult for that matter, having them learn my mannerisms, what it's like in the clinic. And what I found in the last year is that one can do meaningful desensitization visits via teledentistry with live video. So that's, a really good thing. Secondarily, and I'm sure you all have had the experience that some of these nonverbal or purely communicative patients sometimes won't tell anyone that they're in pain or having discomfort. Just using still photographs, if you have the parent take an iPhone and shoot some pictures and send them, is a marvelous tool for you to say, you know what, that ulceration probably really hurts. I'm going to prescribe a chlorhexidine or some other oral medicament, and I really want to see him in the next week or so. Obviously, it's more challenging now in the COVID times, but in COVID, what I found with my restorative dental colleagues, pediatric dentistry, is that this teledental means is a wonderful triage to see how important is it, and do the risks outweigh the benefits of a patient coming in to the clinic now? Should they, as they say, break quarantine and come in? It's been a fantastic tool. Shifting gears, there are a lot of turnkey solutions, both for synchronous or live video as well as asynchronous, like store and forward either written text or photographs. My website, and this is not a plug because all these blogs are free, www.americanteledentistry.org, has probably over 50 blog pieces and a bunch of reference papers that you can download on all teledentistry topics. But a number of our partners offer these solutions, either synchronous or asynchronous. I wanted to can I share my screen just to give an example of one of them?
Yeah, go for that. That'd be great. I really hope that you can actually show us what this
is like. The dentist has to ring a rack in 5 or 10 minutes, maybe, depending on what you get told, Lorna.
Okay.
Right, sorry, I think that's just someone's.
Can you see my screen now?
Yeah, perfect.
Okay, let me just move the panel of us. So on the upper right hand, it says contact. This is an atypical use because it's a nonprofit organization. We're not treating patients, nor are we rendering any clinical services. But when I click on contact, it says text us to ask a question. We don't address individual dental problems, but pretend
pretend this was your office, you'd have a different message saying, if you're a patient of record and you're having an emergency or any general question, please text us at the number below. So I'm going to put in my own cell phone number. And I'm going to say, my tooth is hurting. Sorry that this is, so put your first name in. Of course, there's a robot feature so that people just don't text your practice 1,000 sales messages. And then it's been submitted. Can everyone see that? The back end, so in the practice, there is, one sec, I need to. Okay, this is the dashboard that you have for your office. And next to contact, do you see, oops, let me close that. When I put contact, it brings up my name and my tooth is hurting. And so what I'm able to do is then write a message. Hello, I believe you haven't been in for over 6 months. May I ask you some quick questions? And with this software, you can template these questionnaires. So you could literally pre-send an update to medical history, dental history, etc. Okay.
Can I ask, Mark, just
yes.
the landing page there was your association. I
Yes.
imagine that when you use software that has your clinic on the landing page.
Yeah.
Now it is, so like the Dublin Dental Hospital, contact us for a remote consultation, that kind of thing. Would that
Yes.
be the way?
Right. So
okay.
you would
and
both
this
yeah. Go ahead.
This message that just going to send here, this goes to the person's email, mobile?
This is completely encrypted, and it's a cloud-based system that can plug into either your website or your practice management software. So if you look at the left side, you can route the messages to general contact, to a clinical person like a dental hygienist, dental assistant, or in America, if it's a finance issue, to the person who coordinates the insurance collections, etc. You can also send intra-clinic messages back and forth. The cool thing, and I'm going to try and do this for you, although it's hard with multi-devices, but what I am going to do is go back to my web page, and you can, when you normally use it, where the cell phone number is, when you're using the Rhinogram app on your phone, you can take pictures with your camera and they get sent fully encrypted, and they would pop up on this screen where I've got the conversation. And again,
so the patient needs an app?
The patient will use an app so that it's encrypted end to end, and it's free. It's a free download, I believe, in the App Store. So I'm going to take my screen off. I don't know how to do that.
You know, stop share, is it?
Yeah, I'm looking. Hold on, I have to get the.
I can stop your sharing if you want. Would you like to
stop sharing? That would be great.
Okay, no problem. Okay, and I'm just going to go on my screen, and then I'm just going to stop sharing my screen here as well.
Okay, so I'm back. So that's just one app, and that's a somewhat expensive service. I believe it's, it might be a few $100s a month. The good news during COVID, and this is what I wanted to get out there for you guys, is there's a Europe-based telemedicine software that's an app, and then obviously a cloud-based browser accessible one called Compu Group Medical, CGM LV, ELVI. You don't need to write this down, because if you go to the American Teledentistry Association.org, I wrote a blog with all of the links to demo this. They're offering their software 2 months for free during COVID. So if you needed to access patients and in this emergent time, you could use it, and it's very turnkey. It's not even an install. The other one, and this might seem like heresy for you guys, but the American at-home aligner company, Smile Direct Club, is giving their software for free to any dentist. So I've got another blog on that you can get the power of their app so that you can interact with your patients with that encrypted app between you, your patient's phone, and your email or website. So again, there are a lot of companies offering solutions for free right now because we're really in a pinch. We can't see our patients physically.
Mark, I'll be able to get those web addresses and send them around as a follow-up to all the attendees, if that's okay.
Yeah, that's fine.
Mark, can I ask about the rhinogram that you're using there? Does that actually link into your electronic dental records? Does that then, can you transfer those messages into your patient's chart?
Yes, so it depends. They interface with at least a dozen electronic health records in the States. I believe it's the way they've written it, it's very easy for them to interface with just about any type of software. They have a huge business in telemedicine. I know there's a network of something like 30 pediatric medicine practices that use it. And it's private practices, not university or hospital linked. And so in the medical, for those of you at hospitals that have, the big name medical records, I know it interfaces with all of those as well, not just dental software.
Mark, I'm very soon going to open this to attendees for questions. And before I do that, can I just get a sense of what proportion of your special care dentistry is teledentistry?
Well, I've been increasing it more. It's interesting. I think the best evidence-based answer is now during COVID. I decided to call every patient who we canceled for routine appointments and offer them a virtual visit check-in, make sure the appliances looked okay, oral health was good. And my scheduler the other day called and said, everyone's refusing these visits except for maybe 3 out of 10 people. And I said, well, send me the list of who's taking these appointments. Sure enough, it was all patients with special healthcare needs, because the parents realize they don't want to lose touch. They have the questions. They're taking care of many different, of the patient's medical dental needs, as well as schooling needs, aids at home, et cetera, et cetera. So they're invested in the treatment quite a lot. So I've done a lot of those, and the patients really appreciate it. I think that it gives, even though we as dentists like physical touch, it still gives a continuity of care in their mind.
There you go. Isn't that interesting? Something really hard about that. So I suppose there's at the moment, this is very much on the current COVID situation, but it may be that this is something that might drive us forward, Mark, into what probably would have taken 20 years, or 10 years. It might be that we end up in a situation with online or teledentistry that might progress for our patients.
Did you see there was a New York Times article about telemedicine in the UK? I'll send it in the question and answer link. It basically said COVID advanced telemedicine in the UK by 10 years, literally within a week. So it just goes to show, it's a very good article. I'll send it.
Thank you. I'm going to ask, is there any questions from the attendees, or do any of the panel want to come back in on any of the conversation that's been going on there? I'm opening the floor.
Hi, thanks everyone. That was extremely fascinating, hearing all the different aspects of and applicability of teledentistry. I think what I've learned today is that it's not just applicable in within this current pandemic, but it's certainly going to hopefully have a big role to play after the coast is cleared within special care dentistry, using those apps that Joe and Helen and Nicholas and Mark all mentioned. Very, very insightful. I suppose just a comment that I had to make, that I'd like to make, and it's specifically about Nicholas's kind of study that he carried out and its use in with dentists, but as well, I was thinking possibly training non-dental professionals within care home facilities, for example, to carry out these kind of virtual clinical examinations, given their validity that Nicholas has mentioned. You know, using the intraoral cameras and other aspects. I thought that was something that we could certainly look towards.
Absolutely.
The future.
Absolutely, yeah.
So one of the things that I've looked at is training ancillary personnel, and although I haven't published, I've worked with some colleagues in training basic technicians to do acceptable photographs, video capture, as well as having just the basic schedulers be comfortable with these modes of transmitting information with teledentistry. And I think from patients with special healthcare needs, it's essential that we're able to enlist these dental personnel like hygienists, nurses, technicians. What I've seen, and that's the remarkable thing about these companies like Smile Direct Club, is they get remarkably clean and robust information that patients who are untrained send in. So can you imagine when you give someone just a few training sessions, and I have in my office, the level of photographs are amazing. Having these store and forward record sessions then sent to the practitioner to review for an initial triage is such a profound savings of time, efficiency, treatment planning, and then discussing with the patient, because then you can get on a live feed, bring up the picture and say, look, this is what we're looking at. And again, I apologize, I haven't been a restorative dentist in over 20 years, but these are things that really are high on the list for restoration and need remediation. I want to plan X, Y, and Z visits. It's really been amazing just from a communication tool standpoint.
I'm going to bring in Alison. You said you wanted to ask a question of Mark. Is that right?
Speaking here, very nice to see you again. Mark, I kind of flinched at something you said, which was when you have disability, having something is better than nothing. And I'm only really interested in teledentistry when it can, in the long term, when it can add value. And I'm thinking that what is the single thing? I see this as a great of benefit of people who perhaps their carers haven't got time to bring them in, but you can get, as our restorative consultant was saying, a really, really extremely good clinical picture. And I would like to fuse both of yours together, as in that you've got the quality of what the consultant restorative dentist was able to show us with an intraoral camera. And wouldn't that be wonderful if they were in group homes, for example, where staff could use intraoral pictures and intraoral cameras, so we're not doing best guess, because I strongly believe that nothing should be in place long term if it isn't accurate or really good quality, especially for people with disabilities who often get poor equity because they don't get the choices or the quality. So what about quality?
Yeah, well, so I think the spirit in which I offered the quip of something's better than nothing has to do with my experience in America, where there's definitely no health equity, particularly with dental patients with special healthcare needs. So one of the battles that I've been fighting is there are many children, and I really only treat patients up to about age 20, who are profoundly intellectually disabled. And when the parent calls a general practice office, they say, oh, no, we can't see them. You know, we're not educated enough. And so these parents sort of go around and around. They go to some practices, and within 5 minutes, it's, oh, you've got to go to a children's hospital, or et cetera, et cetera. Yeah. What I think has to be a long-term option is to have the ability to triage and talk to the parent and or patient prior to even meeting them as a patient. In the States, there's a movement that you can't have a doctor-patient relationship without physically seeing them in the office. My argument is it's better to have that first virtual visit, okay, to basically come up with a plan rather than force the parent, maybe even to come at a great distance, to come in and maybe not have as an enjoyable and effective in-person visit. So that's what I was relating to, that it's better to get people in the system than exclude them overall.
I've been working with the Lighthouse Project in Ireland, which is probably one of the thing that Ireland is extremely proud of at the moment. This is a patient portal where the patient owns their own medical record. So we have telemedicine integrated into that, and it's been really amazing, because as our consultant, restorative and psychologist said, it's about trust. For me, I've been coordinating care for people locally, but because they're able to come in via their portal and talk to people they trust, they are actually happy to go externally to see dentists in emergency centres. This has been amazing. So I just wanted to sort of say that I see this as a reasonable adjustment in Ireland, where we've got excellent care for people with disabilities, because we have dedicated services, a specialty over the in the UK. But I would love to see this as enhancing and being the reasonable adjustment rather than a piecemeal things. And so it's really positive to see everybody embracing it and moving this forward. Thank you very much for I'm going to enjoy looking at your blog. Yeah.
What's the name? It's the Lighthouse Project.
The Lighthouse Project. I can send you details. Patients. I see patients with hematology, oncology, and hematology and hemophilia. Patients make their own appointments. They can have consults. We can send them information immediately. They have the ability to show bleeds or to order their own treatment, all through an app, and telemedicine is fully integrated into it. So it's really state of the art. New Zealand has a similar system, but I've always been slightly on the fringe of it in dentistry, but I'm fully integrated in the team. But COVID has shown me every single bit of that program, and I've been absolutely gobsmacked by just what good clinical photographers patients make. I'm having beautiful clinical photographs coming back with patients with lenses on their cameras, beautiful, with rulers to show me scale. And so I've been gobsmacked just at the clarity of what I can do for diagnosis. Yeah, Lighthouse.
Thank you very much. I'm going to interject. I'm going to bring in Kirsten, and I believe that's Patrick Fitzgerald there. Is it? Is that
Patrick Hogg? It's Patrick Hogg. I'm the Fitzgerald part of the family.
Pardon me, Mr. Hogg. You're welcome to the to this webinar. Kirsten, you're about to say. Kirsten,
I lost you there a bit, Kay.
All right, go ahead.
I lost you there a bit in the. You went a bit wobbly, but no, I came in a bit late, sorry, but I just was thinking about how you could use this and how we could try and bring it into our model of care that we're trying to design for children's dentistry. And I think Alison and you guys in special care dentistry are in agreement that we need more regional centres with dedicated teams that we can network better with, and we've done quite nicely working on cleft services with that. So I think that although the idea of tele-dentistry is lovely, I still think you need to have those kind of human connections and trust. So I think it would be lovely to be able to develop something like this with our colleagues in primary and secondary care in the regions, and to start in that way, and to start with a clearly defined network of people, and I think that would be the way that I would love to start something, and to use our dental nursing team to the best of their capabilities with taking photographs, and often they're so good at encouraging patients to do things that we can't get them to do for one reason or another. And I just reflect often, and Ahmed knows from spending time in our clinic in Crumlin, that very often the situation is so obvious waiting list for general anesthesia. So if that could be done remotely, it would be super. And there's always going to be patients for whom that won't be suitable, but there are, there are plenty. I could imagine myself sitting in the tertiary care hospital with the patient's chart, and then having all the access to all their medical record, and then being able to have a consultation with somebody like Maura, for example, in the community, and with the family there, and to be able to discuss the idea of what we might do and the pathway, and to introduce the family to the service without them having to necessarily come all that way, because it can be so hard for people to travel.
Kirsten, absolutely food for thought. So I think this conversation today really let us see where we are at the moment and our current needs, but also probably see the potential for the future of special care dentistry in the new era of COVID and teledentistry. So what I'm going to do, I'm going to call this now as the end of the session. We have about an hour and 15 on, so it's been a huge contribution from everybody. So I'd like to thank all of the guests for coming on and sharing your expertise. For me, it's been an amazing opportunity to collaborate with such esteemed people from different areas and different expertise. So it's been lovely. It's been really nice. I hope this has been beneficial for the people who have attended as well. And if anybody has any communications that they want me to send to all the attendees, you have about 23 hours to do so. So Gurmín Mágah agus Slán go fóill.
Slán.
Bye.